Institute of Virology under ICMR, Indian Council of Medical Research, Bangalore unit. So just I'm honored to introduce him to all of you. So he obtained his MBBS from Sri Devaraja Arts Medical College, Kolar, and Rajiv Gandhi University of Health Sciences. And later he obtained his MD and PhD from National Institute of Mental Health and Neurosciences, Bangalore. So under Talent Search Scheme Fellow, sponsored by ICMR. His expertise areas are virology, emerging and re-emerging viral disease, biosafety, biosecurity, and immunology. And to his credit, he is having more than 80 research articles published in peer-reviewed index journals with H index of 21. And he is having 2 book chapters. And he received several awards, including COVID-19 Merit Certificate from National Institute for Transforming India, that is Niti Aayog, we call it as, and ICMR for tremendous support during COVID-19 pandemic, and received many oral and poster awards in national conferences, and also received 3 travel grants for attending international conferences. Sir, we are honored to welcome you for this 1 week GAN program. So he's going to deliver the talk on Indian context on emerging and re-emerging viral diseases, emphasis on KFD and NIPHA viral infection. I think probably you will be enriched with his knowledge, what he's going to share during another like 1 hour or 1.5 hour. Okay. So over to you, sir.
That's fine, sir. Yeah. So my voice is audible, right? Yeah, yeah. Thank you. So thanks for the introduction, sir. And at the outside, I would like to thank Dr. Devijendra Nath Reddy for giving me this opportunity and including me in this coursework. So I'm very happy to see you here, and it's my first visit to BMS College. So I'm very closely associated with Bangalore. And Dr. Bapi Par, thank you, sir. He's the expert who is here. I think you should take maximum advantage of him. Yeah. No, because your experience, the area you have worked on, it's very good. And most of the topics sir has taken in a global perspective. So what I thought I discussed, we'll go in the Indian context. I'm basically a clinical person, so where I'm more into the research we have done. So here I would like to share our experience and Indian update about these viruses and what is happening in India situation as of now. To show there? 1 second. Yeah. Okay. Okay. So before I start, I thought I'll have few minutes of discussion about Indian Council of Medical Research, our institute, and what's happening with respect to emerging and biosafety issues in our country. I think you people are aware of ICMR. You might have heard. Maybe this thing has come when the COVID started. Before that, ICMR is one of the oldest institute in our country, like 1911, more than 100 years. So it's not bit higher. Yeah. Otherwise, I need to be more loud. Yes. Okay. Since it's a small room. Yes. Okay. Thank you. So ICMR is the oldest institute in our country, 1911, more than 100 years. And if you recently come across Salumarada Timmaka, who expired, she was also born on the same date. And recently when ICMR Foundation was there, she expired. So it is equivalent to that. Just to give instance, she's 114 years. So we can tell it is 114 years old institute. and the mandate is to give funding for medical research. So this was there since long time, and now in the past decade things are changing. So we are also approaching towards One Health, where we have integration of veterinary fisheries, where we are going on that. So under this ICMR, we have 28 institutes. So 28 institutes is like, so before that ICMR is a autonomous central government body under Ministry of Health and Family Welfare. So this body works immense. So in that we have 28 institutes under this body, where like you have tuberculosis. So we have National Institute of Tuberculosis Research Center, which is in Chennai. You speak of cholera, we have National Institute of Cholera Research Center in Kolkata. So when we speak about epidemiology, National Institute of Epidemiology, which is in Chennai. And when we speak about virology, National Institute of Virology in Pune. So like as per the national requirement, whichever the important diseases are there, which a country's priority, so the institutes are based on that. So the number of institutes can expand on that matter. So under that, we are speaking about, which is a premier institute for virology. So this, it's almost like more than close to 80 years old institute, the second oldest institute in our country. First is NIN, National Institute of Nutrition, which is in Hyderabad. So this is our second oldest, and the mandate, as the word says, virology. We are working on virology since 80 years. We are working on this, and the virology, since it is sitting in one zone, like western part of our country. So there are also some field stations for this. Field stations in Karnataka we have, in Bangalore itself we have one field station. Another is in Alapi in Kerala, and one more is in Mumbai, Maharashtra. We had Pradesh, but anyway now it has become an institute. So we are given the charge of this unit. We are working on international and national network projects. Since being the tag of National Institute of Virology, so we are accredited for WHO for few networks, like global elimination, measles, rubella. These are the viruses which we are working. The network, and we are working on that. So this very briefly, government, since we are in Karnataka, so whatever is the requirement of Karnataka, we need to fulfill their criteria. Like there is a Zika outbreak, there is a KFD outbreak, and there is any new monkeypox suspected, or NIPHA coming up from the border of Kerala, then we need to be more alert, and we will be in the part of that. So taking this into consideration, our work, we will have some discussion of Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, which is the most higher big ticket project scheme, which is taken up by Government of India, so to encourage the health in our country. So we witnessed two pandemics, influenza 2009 and 2020 COVID-19. So what? So when we see these viruses, when they suddenly popped into us, I think COVID-19, you people are well. Wave 2 had significant impact because of the ventilation. There's so many issues which we have faced, and you know, see at the background at the virological level. So COVID-19, SARS-CoV-2, yeah, we can call it as, because we are science students. So when we tell what is the mortality, it's very, it's just lesser than 2% when we take average, and we are like shaken with this virus. But do you think of the viruses where Dr. Bhupi sir has presented his few things like NIPHA virus and all, which we have some discussions. Their mortality is quite high. So picture and spread all over how things are happening. So considering, keeping into these things, there are many hidden viruses which now we are trying to explore, but still we are not able to find many. We can anticipate any time these outbreaks, and which can go epidemic, pandemic level, significant impact. There was a series of laboratories were activated, maybe in a span of diagnostic laboratory, which is again under these laboratories were activated at the level of medical colleges, at the level of, in Karnataka, we have many medical colleges are there, you know, BMCRI, which is the state level laboratory. And when we think higher for a region, JIPMER is there, which is a regional institute and a COSI code area. So they have set up few institutes which are capable of handling higher levels. So these laboratories all over India network activated in a short span and they started testing. And if you have seen our activation, even private people came into the picture. That was a very excellent coordination, which we have set an example at the improvements, diagnostic kits development, and we could make the indigenous vaccine, which was also in a very short span that rolled out, and it has given, and we also supported our neighboring countries also. So with these and all, so they in a higher level, National Institute of Virology able to serve a new institute is coming up in Bangalore, and we have one central zone which is coming in a north. This can be handled at the zonal level. So the mandates are what's happening, and institute, which is under the umbrella of 13 ministries, where we have ICMR, DST, DBT, CSIR. So that's very important. Maybe in a 2 to 3 years, health, which but India is gearing upon that also. So these things and all people should. And what was the why we are like how much we are progressing in this science area in our Indian context. Okay, so in the content I'll be talking about brief group classification. So some viruses emerging and re-emerging in Indian importance on the KFD virus because it is our state issue. KFD is a big problem since we are facing till 7 decades. It is ongoing and still we are fighting. And NIPHA virus, Dr. Bapi has already covered the NIPHA virus, but I'll be speaking more in context of what we have done on fields and what is our country doing on that in the current stage where we are standing. And some other emerging, re-emerging, just the names I'll be taking time. Next slide. So risk group classification, I think Dr. Bapi has already covered that in his presentation. Hope he has already taken. Yeah, so we have the viruses, even bacterial, parasite, whatever the factor. So we'll classify them. So why the classification is important is very important. Way to handle and how much pathogenic is that infectious agent is to us. Like the pathogenicity of the organism is one of the key factor which is taken to classify in which group this infectious agent falls in. And the mode of transmission and host range of organisms. So what and all mode, droplets or contact, or it is by only by animal or vectors are there. So there are so many modes in which we can take into thing. And the host range, whether humans are only host, even the animals are also involved, those factors also taken. And availability of preventive treatments, very important. If there is any specific antivirals, that is very good. If most of the virals don't have treatment as such, only few antivirals are there. And any vaccines are available for that, and how much it is capable to cause disease in humans and animals, and the potential of spreading it from one point to higher, like epidemic and pandemic level. So these factors are taken and they are being classified. Why these classifications are very important is because the same thing goes on to carrying those agents in different biosafety levels. So group 1 is no or low individual and community risk, so very low risk. So example is rotavirus, which commonly cause GA infections in pediatric population, and immunocompromised adults also affected. So where rotavirus can be a group 1, even if you are seeing the malaria parasites, which sample is taken and slide here and there in a bench open HC hospitals level, which goes in group 1. Group 2 is a moderate individual risk, low community risk. So example is dengue virus. So where we use this, we have chikungunya virus, we have JE virus. This and all comes in this group 2, which are of moderate individual risk. When we talk about this group 3, it's a high individual risk and low community risk. So when it infects the humans, it is of high risk and low community. That is one example is we can take. And some SARS-CoV-2, even Zika virus, to isolate these viruses. We go handled in biosafety level 3. Risk group 4 is high individual and high community risk. NIPHA is there, and Marburg is there, CCHF, Crimean Congo hemorrhage virus. Here, mortality, where treatment options are very less, vaccine in a development phase, and and one example I can yellow fever. So when you take this yellow fever in other countries where it is endemic, they put in a risk group 2, but for us yellow fever will be risk 4 because we don't have that virus in our country. But you take the KFD risk group 4 because that virus is not circulating in that environment. So this manual I have given, which is by DBT and ICMR, which has given details of biosafety level 3. So what are the things? Yes, next slide. I can do it. Okay. So emerging virus, the word tells emerging, which is a new virus, which was previously unknown, which is detected for first. So one instance is ARDL network, maybe about 10 years back, when they were retrospectively screening the samples, they identified first time Zika virus. This happened first in Chennai, then later it was detected even in Ahmedabad. So this tells like that virus, though we know it is been circulating, but it was not reported. But once it started coming identified in our human samples, then we can call it as emerging virus, which is firstly detected, which was not known previously, and it can cause. So re-emerging virus are which are, we know that virus are there, which is there, and they pop up maybe biannual or yearly basis, or maybe frequency of 5 years, as and when they. So in known for some time. They have come across. The best example is we can take it as even this dengue can be taken into picture, infe be taken, because sometimes they are completely controlled and sometimes we see the spikes will be happening very in a high number, and this cause significant public impact. This now showing trends in incidence or prevalence worldwide, and sometimes it happens which were not reported in one area, they start reporting in another area. Okay. So zoonosis, it's a very important, which is attracting the recent scientific world, where we see the diseases which are coming from animals to humans. So this is one of the area where the One Health has been building up its very strong foundation on these things. So any disease or infection that is naturally transmissible from vertebrate animals to humans. So when we take about this, where humans can act as animals act as a reservoir, where the infectious agent is in the animal and that is transmitted to human, and it causes significant health issues in the humans. So this is a zoonotic diseases. So human get affected directly or indirectly, vector-borne disease, environmental and food pathogens. So this there will be cycles whenever we take a infectious agents, so what I can tell is, for example, we will take any like from animals to humans, we have brucellosis. So where the domestic animals, where they born this bacterium, and when human come in contact either with the milk or with the flesh of that animal, so they are getting infected. So that is from human to animal thing, which can be put in a category of zoonosis. Even when we take this KFD, that can be, it's a tick-borne disease, but still the monkeys. So monkeys, death monkeys, the disease can spread. So these are the thing very important. So when we take in a nutshell, what we know about the infectious agents, about 60% of the known agents are known to cause infectious. Of these 60%, 75% are which are emerging character are from zoonotic. Of the 60%, 70% is in zoonotic nature. 75, sorry, it is like almost 3/4. So among them we can see 75% is are from wild animals and 25% is are domestic animals. So when we take the things, so you can see the majority of the chunk is taken by zoonotic diseases. That is why it is coming in a very significant way, where we need to do a lot of efforts on this to understand and also have significant progress in this area. So this is a global scenario. It was a 2023 slide where we can see all these reds we can see all are newly emerging at the global picture. When we focus about our India, we can see emerging, re-emerging, we have typhoid, NIPHA virus, cholera. These are the viruses where these have been reported at the global level. Yeah. So WHO in, I think this was also 2024, I think, picture which we got. I think if Dr. Bhapi has already presented this, okay. Okay. So just to tell which are the viruses which is in the list of the WHO anticipated, like this may be faced in future. So we need to be ready, so that R&D should happen on these areas. So as I was speaking about coronavirus SARS-CoV-2, we can see the mortality is 0.3 to 3.85 average at the global level. So we could see what it has done to us during 2020 to 22 years, like almost 2 to 3 years. It has made a significant impact at all the levels at our country and also global level. But what's our preparations for this? How we need to handle either the kits preparations or the vaccine developments or any therapeutic aspects. These are the area where we are looking forward and keeping ready for certain anticipated, like filoviruses. We have Ebola virus, Marburg. I think Marburg just now Dr. Bhapi has taken. Arena virus, we have Lassa virus, and coronavirus, SARS-CoV-2, MERS, again coronavirus we have. See, okay. So we have Bunya virus, CCHF, this Crimean Congo hemorrhagic, which is most reported in Rajasthan state of our country, and frequent outbreaks have been reported. So that regularly it's a part where we are handling that. This Rift Valley fever virus, again it is there, and paramyxovirus, NIPHA virus, we can see the mortality 40 to 75%. That's the weightage it is taking. When we compare with SARS-CoV-2, which is just lesser than 2 to 4%, but what about the 40 to 75%? And Zika, we have about 0.1%. So we'll take into our Indian context what India we are facing. So we can see, like again from 2001 onwards, we have NIPHA virus. Again, the Chandipura virus is there in Maharashtra and Madhya Pradesh. Chikungunya we know, and this is enterovirus. Hanta virus in 2005. Influenza, CCHF. Sorry if I said Rajasthan, Gujarat. So that's virus. Initially was in Gujarat, now it is like almost all the states Zika is positive. SARS-CoV-2 2020, and KFD is there 2021, and H5N1 influenza we have 21, and 22 is monkeypox. And then after that I have added a table. Okay, so we have NIPHA again, we have in 23, 24 we had NIPHA, even 25 also we had NIPHA, and in Karnataka we also had Zika virus in 24. So these outbreaks are all on and off coming, so we are all facing with it, and how strong in handling these viruses. So when we see like why is this diseases emerging, re-emerging, and why they are crossing the borders? What is the main reason why this sort of virus? Because you see, in an airport authority, any person coming from Africa, we take the vaccination history of yellow fever he has taken, and is not sick. Suppose he is sick, he's been taken into isolation place, and he's been checked for few days. So there's a base for this. Why these things are happening? That we'll understand in subsequent slides. So the main thing is human factors, a huge population, urbanization in our country, and traveling, bus, trains, airs. We travel now. Traveling is very easy for us today. In one day, we can travel to Delhi and return back. So it's almost like 2,000 kilometers by air kilometers. So this all made so much easy for us, and mass gathering in a huge fairs where we come across melas, Kumbh melas, whatever we do, huge melas. So that's a place where people from different regions come across carrying one infectious agent, and transmitting has become very easy. So environmental, the host, whatever the mother earth nature it had, now it is being getting distracted by this industrialization, deforestation, and one of the thing is like even the bats are getting disturbed. They are moving away from their comfort positions, and they are going to a human habitat where the humans are getting exposed, which is like bats ka normal floras are there, they're getting exposed to humans. So few hypotheses are there with the NIPHA outbreaks in our situation, where I'll be talking on that. So that is one of the deforestation, and ecology is also disturbed. Viral factors, when we speak about this influenza, we can speak, they are potent enough to have that shift and drift mechanism. When they are in the birds and they are transmitted to humans, they have the mechanism of them is so strong, they can be more virulent. So that can have a significant impact. That's why this influenza network is regularly monitoring this influenza in our at the global level, and we are part of that. And viral factors, even the vector-borne transmissions. So we are still trying to explore in our Western Ghats. So we have the Sayadri, so where we have so many ticks, vectors also. Things are not much explored. There are so many R&Ds happening in to understand and like for commonly known scrub typhus treatment is there for that. Excellent doxycycline will work. So it's available at the PHC level. Unless until it is diagnosed, it is not beneficial. Long-term consequences are there. So otherwise, we are identifying surveillance and evidence telling that these are available in India. Measures can be taken. It's all treatable. So this one is the railway network. So we could see the networks where the traveling has made from one end, any part of the India to traveling to another. We have the railway networks. So this tells us, just to tell like even the air networks we can see, just the transportation has become so easy for us. In the parallelly, even carrying whatever the infectious V agents to moving to one part to the another part has become very easy. That's how it started spreading to us. And this is one interesting migratory birds. During a seasonal time, we have seen the birds. For India specifically, we are showing some areas from northern part of our India where the birds during the specific seasons, they migrate to India, where they can carry the infectious agents from the other continents, other countries, and they fly and they can put up in India. And we can see even there are so many bird sanctuaries. Sometimes there are situation in the Kokkorebellur in Mysore, if you have heard of. So there was a situation where birds were dying. So what was the reason? Then it was detailedly explored. Even we and IAC also we took in that, and we could see this Clostridium tetani, which was there and causing the death in so much of the birds. And it happens like so many areas these birds are there. And even when we speak about this JE virus. JE virus, again, the RD carrier of this and comes and put in the fields where the pigs can take and amplify. So these birds plays very significant. And avian influenza, where birds play role. Even in India also people tell there are hypotheses birds had a role in this. So now we'll speak about KFD virus, which are one of the interesting topic and my topic too in this. So what about this Casanur? forest disease. And I think you people are aware, most of the viruses got their name when they were first isolated or wherever the first they were discovered. So Casanur is a forest name in Shimoga district of Karnataka, first time when it was discovered. And this was again identified by our own institute, our senior directors who worked in this area. So they are identified in 1960s, they have identified. Okay, so this agent is as of now in the when we see at the global CDC, WHO, or in our EBT and IC, it comes under risk group 3. What recent risk analysis and mitigation, we have found that since this virus is circulating in humans, monkeys, and ticks, I know about the life cycle of that. So this comes in risk group 3, handled cell 3 on that. So whenever we speak about the isolation of the virus or any monkey studies, we need to do in BSL3, or you are doing any tick studies, or any you are doing a monkey samples, because most of the monkey biopsies in the fields are sent. So that we handle in BSL2. BSL2 can be handled only for human samples, where we need to put a lysis buffer and we can handle with a good biosafety results. So it is in Flaviviridae. This I'll not go much because Dr. Babi has since. So this is a positive to the structural, capsid, membrane, and we have non-structurals help the virus to protein, which will be helpful for it to enter into the host and amplify manifestation. As a target, it is a flavivirus where we are facing lots of challenges with this virus because the dengue, the well-known virus, is the same West Nile, and we take Zika virus, and these viruses and yellow fever we don't have, but this and all in the same thing. When we wanted to test in a laboratory, because any kit you test, it should be like more than 95% sensitive and close to 100% specific. Then only we can take the test as valid. But once we speak about these viruses, the cross reactivities are very high. So we are facing with that. So now uh, in the envelope, we are ED3 domain. It has three domains, one, three domains. So ED3 domain seems to be more promising for a diagnostic marker. So we are doing so much R&D on this. So in shortly, we may be coming up with a better diagnostic kit for KFD testing in our state. So it's a very interesting life cycle of KFD virus. So it's a Western Ghats story. You have seen the in these ticks. The ticks are Haemophilus ticks, which there are so many subspecies, but in general, the Haemophilus carries the majority of these viruses. So this tick, when we can see, this is the and you have larvae, and after larvae you have nymph. After the nymph, it matures form cycle. This the tick cycle starts on. Typically, it's a seasonal based. So now season, even last 2 weeks I was in Chikmagalur to do one of the KFD, where we see it this month. So slowly the nymph activity is starting. By January we see typically the cases will peak. After that it start declining. Till June we have seen the cases are coming up. But peak is in January and February. This we are getting since decades. So when this virus, it goes through and transmit from eggs also. From eggs means it's stage. Lays the eggs where the virus are there in this eggs and it is going to the another stage. So this how it is being transmitted. Fact is that these viruses are there in this, and what about the other season when we speak about maybe July to September, where cases are not been. So most of the time this will be in a dormant phase. So okay, if not, where else the virus is circulating? So uh, host they carry these viruses. So when these ticks, either the virus can be present in the ticks or those are carrying the viruses, and they are not manifesting any symptoms. These animals, they are manifesting. So when this ticks blood from animal, it is you. It is sense what you guys are. So you are very active and energetic. So they are like you can see a classical pictures on a forest leaf host. Whatever comes, either animal, warm-blooded animals. It can be either human or whatever. They get in them. That's why especially the trekkers, what you say, people who are interested in trekkings, these things and all. Now the state has given their notice also, be careful. And these seasons where ticks commonly carry these infectious agents. So whenever you go, please follow the instructions and whatever is being instructed. They human. So that is one way it can come in contact with the human. And you know, the people who are working in forest, we call it as something a fringe area. It's like the persons who are close to the forest and their livelihood goes every day. They go to the forest, collect some wood or honey, whatever. So they definitely come in contact with the animals. And sometimes it happens cattle to graze them in the forests. So these ticks can even go and sit in the cattle also. And once they come back, somehow cattle are not manifesting any symptoms, but the humans, the cattle, they clean cattle or they take care of the cattle. That time they can come to humans and they will bite. When the ticks bite, or if you don't look into the ticks, it stays there only for days also it can stay. So if at all ticks carry any infectious agents like KFD, so it will inject and from the dendritic cells, it starts slowly amplifying and enter into the endothelial cells. So ticks come, this KFD is a hemorrhagic virus and past we can see about almost close to 1 decade, even it is slowly manifesting the neurological symptoms also. So where our Manipal, Dr. Kavit has put a few papers on this because since it's a Western Ghats area, most of the goes to Manipal since it is very close by. And this I've given in brief about the tick cycle and how about this, where this will be circulating and humans, how they come in contact with these viruses. Okay, so this is a geography. What we have seen is this is where we have very good that is favorable for the tick care and also intermediate host. What I was speaking about these small mammals, rodents, and all they are there. So and the countries and the states which are affected, we can almost like 5 states. These virus where 5 districts of Karnataka were affected. But now, past years, we could see the virus has spread since of Maharashtra. Also, the is affected. Come down here, we have this and Kerala affected. Has spread throughout its Western Ghats. What happens unless until we look for, we'll not get the virus. So, it's all these areas. Samples for different. When we looked at it, it was very interesting to get IgG antibodies even in Gujarat and some part of Bengal. We don't know how it's happened, but we could get this. So it can also be, if at all, unless until we do plaque test, we can't tell whether it is because of KFD specific. Some cross reactivity can also, but somehow they are done, and even in this area also cases have been reported. These are the real pictures. It's is there. She is a central rapid team response from Government of India. She visits the sites. I have taken from her. She has taken from our Shimoga area where she visited. You can see the deforestation and the people, how close they are with the cattle. You can see they are working. And there is a picture. And they carry the wood. You can see the woods to the work and all. So if the woods where the ticks can be there, and if a person is carrying, it goes to them. So interestingly, when last 2 weeks I was in Chikmagalur, wood collected and people are carrying, and people you can see they usually in forest and they hardly put their shirts, they are bunions, and state is trying to provide them the repellents, and we are trying to encourage, but still resistance from the people are very quite high. So this the pathogenesis part, I think Dr. Bapi has already covered this. So in general, for any flavivirus, it is get tend dendritic cell or the epithelial cell when they after it's the host cell, so it and this once the comes in, into chromosome, it is acidified and it is released. The material replicating there, and it the and we have endoplasmic retinaculum where the protein structural changes form, and the vacuole is formed and it is released. This the incubation period is 8 days. Once the tick bite, we need to observe the patient for close to 7 days, and also sometime even for more than 10 days also. So can manifest symptoms. Classical this is any other viral infection. It can cause fatigue symptoms, which is common with any viral. But two phase. So the phase one where initially it can manifest with these symptoms and it can wave off. Otherwise, in a span of maybe in another 1 or 2 weeks, it can cause a cycle of fever where it can cause hemorrhagic or neurological symptoms. So that 10 to 15% of the people can go in the second phase. It can affect like most of the things, like the liver infections, liver things. It's not changing. As I said, the second phase of fever, number of cases, there is a second phase characterized by meningoencephalitis, where the brain cover brain cephal infected, and this happens after a period of 7 to 21 days of the first phase. And this is the phase where it is more. We have seen people who are dying in the what the data we got. We could have discussion with the clinicians also. People tell these belt people commonly they consume more alcohol. So people who take more alcohol, we have seen chronic alcohols where their livers, there is some compromise in the liver also. So people who are dying, the mortality is almost like 5 to 10% for KFD, which is reported till date, and it is true, existing the same in almost all the belt of Western Ghats. So more people who are dying is having a liver manifestation. This was one of the thing which we are able to observe. So there, and it is a hemorrhagic fever. The blood and liver plays a significant role. So there is more prospective studies in these areas required so that these people can be put on a priority to take care in these belt areas. Next. I think you can only change to next. Okay. So here, whenever we have a case definition as per NCDC, Government of India, we have NCDC area where we have seen whoever is working in this area will provide you the case definition. I think you people are familiar with case definitions. Otherwise, I can tell one or two words on that. Yeah, okay. So you have, for example, SARS-CoV-2. So a patient is coming to hospital. How the clinicians decide by his experience, he knows okay, this is what the person is suspected for. But for a KFD, there's a very good case definition. So he should have a fever, and very importantly, he should have forest exposure. So we have seen cases coming from Bangalore suspected for KFD. So do we really take those cases? Yes, we see for the case definition. We'll ask whether the person has gone for any trekking to Western Ghats in past 1 or 2 weeks. We got this history. People, we got cases from St. John's, we got from Sakra, they're requesting for KFD. And it is very unusual why they're sending samples because this happens like they had trekking in that area. Or we also got cases from Esargata where there's a monkey failure, monkey death. So that also we have seen. So person who goes close to the monkey death proximity also can be taken into suspect of case definition. So there's a standard case definition for KFD: person who is having fever, body pain, conjunctivitis, who had a past 1 year exposure with a death monkey, or he has gone to any Western Ghats area for trekking. So these things. So luckily KFD, there is no human-to-human transmission. Suppose one person is infected with KFD, another person is taking care, like healthcare facility, it is not transmitted. It is only transmitted to tick bite. That's the only way it can get into humans. So one thing I forgot to tell about the monkeys, which are mainly affected. In Kannada, they call it as Mangana Kaile. So it's a monkey fever or monkey disease. It's a very well known in the Western Ghats belt. And these things, when humans, we can say the mortality was just 5 to 10%. But when we take the situation in primates, monkey, especially two monkey species, rhesus and lemur monkeys, the black-faced lemur monkeys you see in the forest, they are more affected. Close to 60% is the mortality in monkeys. So they are more affected. So monkeys are the main which can take these viruses from one area to another area. So that also we have commonly anticipated with these monkeys. So we are working very close with these veterinary people. There are some diagnostics which are developing, and also vaccine for the monkeys also, because again vaccinating the monkeys in the forest is not that easy, because take on the at least the monkeys which are close by, which are close to the human habitat, those things are some parts are going on. So now a patient is suspected at the primary health center or sub center, which is a root of our country. A doctor will suspect in a endemic area. So what samples are taken? Commonly the serum sample is taken, blood is taken, centrifuged, and you take the serum sample. And again we have a algorithm at what time the sample is taken. Earlier the sample close to 7 days, it will go for PCR and IgM testing, and if it crosses more than maybe 3 weeks, we need to go for IgM and IgG. We have an algorithm based on that, we'll try to identify. And this, and if at all CNS infection is there, we want a CSF based on the patient condition and his consent. CSF is taken, and hardly there are few laboratories in our state. Only in Shimoga we have VDL, viral diagnostic laboratory, who do the PCR testing, and otherwise we have NIV Pune, and our laboratory is there, and Manipal also does the laboratory testing, because the state now is gearing up like some other places in Chikmagalur, where and all the disease is well known. They want to establish this laboratory testing so that reports can be given as early as possible. So there's a standard things, the laboratory part. When the sample is taken, what you will do, you need to transport. But people working in the fields is not that easy, because they have a batch of sending the samples, the transportations, which is not like a Bangalore situation. So you cannot send the shipment of takes. So this time you store samples. So probably you can store to minus 20 degrees, where the majority of samples stored. Because this sample, if it is positive, if you want to do the further isolation, whatever is the situation, it's very much useful. So better to keep in minus 70 degrees and transport by the standard triple layer packing. You need to send it to the laboratories. So now we have the real-time RT-PCR. It's well established, and which we are using. And I think this is there in almost all these laboratories what I inform. And now even we also have dry down RT-PCR. And ELISA, yes, we have ELISA, which is a whole virus-based ELISA, but the cross-reactivity is challenging for us. We have seen cross-reactivity with dengue virus. Dengue is very well. Even in the forest area, you get dengue. So in 2018 and 19, when we had tested close to 2000 samples, we have found that KFD was close to 8% positivity of total samples what we saw. Then we did dengue, it added up to 8% more. Then we did chikungunya, it added up to 5% more. Then we did both dengue, chikungunya, dual infection. So totally we could tell almost like 25% positivity was there. So in that we can tell that adding these arboviruses along with these things, so it came to 25%. So but the big challenge for was the 75% which is negative. Why those cases are negative? So what are the other things we need to explore in those areas? And it also matters on at what time the sample is taken, testing on that. So we have ELISA also for that, and old generation sequence is there. Yes. But for KFD still we don't have multiplex. We have a single only. Like maybe yeah, flavivirus is taking dengue. Agree. This is a good input. It can be taken. Yeah. and West Nile also we can take together because that is also there with us, where we can point anti for K such. So whatever we have is this NITD double G robust. These are the things and to the much explore. So vaccination, the long back in 1970s, I think, NIV gave a full virus inactivated formalin-based vaccine, which was used. And now, for the past 7 years, it is stopped because we have seen the compliance is very poor, and also the safety, efficacy, and all we have seen there is not much stronger with this. So the government of Karnataka and India has taken initiative to stop this vaccine, existing vaccine. Now their trial vaccines are going on. Now Indian Biological in Hyderabad has taken a phase 1 trial with NIV, and maybe in a span of 1 or 1.5 year, a new vaccine with recombinant technology will be rolled out in our country, especially for this bed. And these are the other areas. Even we are closely, as I said, we are working with IITs and IITs. Vaccines are in pipeline. Maybe once we get the candidate virus, then we can take it for trials under CDSU approvals. So the some part of surveillance is very because I had its clinical part where the epidemiologist in the field what they'll be doing. Now it's like the case definition. The monkey death is very important. So whenever there is a monkey death, what happens? The team will go there, veterinary and the surveillance people. They have anti-repellents. The 5 kilometers radius, they'll try to spray the anti-repellents so that the ticks which and all from the monkeys, as soon as the monkey dies, the ticks goes out because they want the warm blood and it should be viable. Otherwise, start moving. Just go and stay. If a veterinarian, if somebody comes and they want to dissect, because any monkey that they do autopsy then and there to come up with a good SOP for that, so that the person who does, he is also safe on that. And as of now, many people are doing that. And the ticks which are far away, when the person comes started doing dissecting, they go closer. They go closer so that they enter into the humans. These are the ways we have seen that ticks are able to manifest. And also the sometimes monkey has that for long time, and the ticks are very close by. Ticks can't go that far, maybe a few meters only they can stay, where if animals are going close by, they get into them. So these are the area, the forest guard, whenever he sees a monkey death, he'll be intimating the local veterinary or the doctor, and immediate the action by the surveillance people of that taluk level or the district level will be initiated, so that the it is be like sprayed with the repellents. That part happens. That comes, and also we give DEPs to the forest people who are, because we cannot stop the people, local residents going into the forest, but we give them that repellents. And now with a series of R&D, we have come up with some what to tell, pleasant smell, so that they feel. Otherwise, the smell of the repellent was not that good, so they don't. They'll take it from the health workers, but they'll not apply it. So they will tell this is very too smelly. Otherwise, they want to come back again, take the bath and put their clothes in the warm water. Some procedure they are doing. We can see the IEC is working up with these people, but still the challenge of handling this virus has not come up to that level. That's what the awareness program wearing protective cloths and tick protection while handling the infectious materials, restricted access to infected forest areas during outbreak times. So these are very challenging. We cannot hold them. They tell this is our place, my home, I want to go to forest. We cannot stop them like that. But at least some knowledge should be given to them. application of tick repellents to portion of the exposed body, and washing of body and clothes to hot water immediately after returning from the forest. So these are strictly given, and people, we see that majority of the people follow this. And talking about NIPHA, maybe already Dr. Baki has already spoke about NIPHA. I'll be focusing main about our clinical experience in fields, whatever we had in context to NIPHA. So it's a risk group 4 uh, because it can be transmitted either by droplets or by body fluid secretions, and it will be handled in BSL4 in our country. That as of now only NAV Pune where we have BSL4 is handling this virus. Again, it's a paramyxoviridae and genus NIPHA virus, and it's a negative RNA virus which is 18,000 kilobase pairs. Again, the structural part, I'll focus on these clades. What we have NIPHA virus B from Bangladesh and India, where the mortality is higher as compared with the Malaysian strain. So this is the virus structure, and this is P gene codes for CWV gene products, which is helpful for entering into the host cell. Don't know it is, yeah, okay. This global map tells us whatever the area is all the bird habitat, the bat's habitat area. We can see classically when we see this color where the NIPHAs are affected, India, this Malaysia, this Brunei and Philippines, and this is not NIPHA actually, Australia, but it is a Hendra virus which is there. We can see this picture, we can see these star cells where and all the NIPHA outbreaks have been, Bangladesh, West Bengal, Kerala. So this is in our Indian context where we are getting repeated outbreaks. So it is classically wherever, and even in the bats habitat also, Dr. Bhapi clearly said towards the north we can see no much bats are there. That's not much favorable. Within this area, this fruit bat especially, they flies, and we can see these are the areas where this NIPHA has been reported, especially from these 4 areas. When we speak about the Malaysian picture, because the Malaysians is well established, unlike in India, what we are trying to identify how the Nipah is being spreading to humans. When we see in that the bats, the fruit bats, when they eat the fruits, and these fruits are not completely eaten, partially eaten, and it is falling, and pigs come eat these fruits. Then when humans come in contact with the pig, they are getting infected. But the same thing when it happened in India, it was not the same thing. So many pigs were explored, their serum was taken and checked for. None of the pigs had any IgG antibodies for NIPHA. So then what? Then how is the way the like this virus is spreading in Indian situations? So what we try to do, we had a this both western and the eastern Ghats. We have taken so many bats. That was a huge bat survey that was conducted almost like for 5 years, starting from these western Ghats, of eastern Ghats of Bengal, coming to Andhra Pradesh, Tamil Nadu, and going to the western Ghats, Kerala, Karnataka, and many other areas we tried to explore. Most of the bats were positive for IgG, but we could not get any virus as such, but bats were positives. So it's clear like the bat carries this virus. But how is this virus transmitting this to our humans? So which the outbreaks are happening on and off. We can see the possible. This is toadies. No, you in Kerala, it's a very well practiced in the saplings. They put these pots, accumulation of this toddy. They call typically toddy. By morning, it will be a pleasant drink for them. So where bats also taste it because it's a flavorable drink where even bats also, if the bats they're carrying this virus and they taste that sap, its saliva or it urinates through its urine, so that can come into this sap, and when we consume that, so we get exposed. This is one of the hypotheses which is put forward. And the next thing is the fruits where bats are eating and that fruits fall, and human is taking that fruit and not cutting off that part, or is consuming that, and if at all the bat has bitten which is carrying the virus, the chances of spreading to him. So we can see in the recent 2-3 months back outbreak in Malappuram and Kozhikode, what we have seen, we have reported 4 cases, and out of the 2 cases died, and interestingly all are females. So because these people they go and they're in the area, we could see they are housemakers. So what is the source of contacts? When our AP people had a detailed thing, we could explore that one of the house or two houses we could tell trees are there where the gardens are there where the huge bats are there. So and the kitchen is there, maybe window is open, maybe that bats may defecate or throw the urine, so that has passed and carrying the virus these people. These are a postulation we have made because we did not get a strong evidence to tell yes these bats. And we also did catch the bats, and but we have a norms, only the samples can be taken, the bat should be let. So with that also we tried, we could find the antibodies but we could not get the virus in that. And the samples, the environmental samples, whatever the fecal matter or the urines we tried and we tried, but we could not get the virus as such. But the humans were infected, and this happened not in a single cluster. It was like, suppose in Malappuram one case, in one case to second case, it was a distance of close to few kilometers, because we expect it is happening, then it should then. So that picture was not there. So whatever till now we are trying to see, connect that how this NIPHA has been affecting even toadies. We did a huge study, and the study is also going on toadies. The toadies samples are taken, they are tested for virus. Still we are not able to pick up. It's only hypothesized that the bats comes in contact with fruits or the toadies, the human consumption is manifesting. But the evidence we could still not generate that. It is still in a phase. So these outbreaks where after 2018 we can see it's full, which still we can see the cases are happening. Uh, but what we could appreciate the government of Kerala and also the government of India is, now we are expert with this. So whenever, I think 2020, I think we had an outbreak, 23 cases were infected. That was, I think you have seen the Mary Nurse movie also has come up based on this. She has taken care of that patient and she got infected, and she avoided her son and all, and because it spreads, the healthcare worker. So now people are more aware. So as soon as the patient comes with these case definitions, they try to isolate. We'll try to put the case separately, and now even Kerala government also, government of India has made a mobile BSL3s. So the BSL3 will go to a field where wherever the outbreak is happening, and they'll do testing there, so that the main intent is like early diagnosis, containing the virus will stop spreading. Otherwise it can spread very fast, because any mode, respiratory or any of the body fluids, the virus can spread to others. So that part is taken care. But we are the team goes, who does the, we have sent RRT, we call rapid response team, both at the state, at the central level. The people constitute of experts. We have veterinarian, we have clinician, we have basic, and we have entomologist, who will be a team of a national level. They goes to thing, and we have seen that the mobile BSL3, I think it's just a 4 years back we come across mobile. Before that, the laboratory was established in a cozy code government hospital in a span of 2 to 3 days. And now our NIV has also come up with a case which can be diagnosed immediately at this spot. So then later, once it is diagnosed, what are the precaution taken need to be that the main target is to not to disturb the case so that the virus spreads. So again, now one next case is positive. Where is that case? Who are the primary contacts? We will tag it as a index case whenever the first case is there. Then we'll go for the primary contacts, then the secondary contacts, then tertiary contacts. The number increases. Maybe because of one case, in a span of 1 week to 2 weeks, the latent period is close to 14 days, the incubation period. So when we see that until the 3 cycles, close to 300 400 peoples, the people will flow in, tell them wherever you stop, and those people again, the secondary people are coming in contact. So those people will be observed for 28 days. So the first sample will be taken, observed, no symptoms. At the end of 28 days, we will do another sampling until we clear them. They are okay, you are free. They will be in isolation. So this is how the government, we should appreciate the government of Kerala and also the central, where they are trying to see that they are trying to isolate the virus then and there. That's how till now for luckily it has not crossed the borders of Kerala. People are, migratory we can think of, no doubt on that. But actually, that's one of the reason I said in bats, the local bats in that area. Within the IgG, we are able to pick up. IgM and serology level in the bats is showing up there is this virus, but virus we did not pick up as such. So it is evident that virus is there in the bats. It is there. Migratory from other areas means unless until no, they're done. They're done. They're done. So we take their oral fluid, fecal, and even the blood is drawn. Only this much is permitted to take the samples, and there will be a forest guard also with us. We need to leave the bat immediately. We cannot do anything because there is so much animal ethics for us that. And we have found the antibodies are circulating in them, especially the Kerala belt. Even Karnataka has shown positive for NIPHA antibodies. Even in Karnataka, we have done these studies in this area close to this Kanakpura area, where we have shown the bats, they carry the antibodies. So, like, luckily, till human has not come in contact, but no, 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 no. Isolation, we could not do it. That's one of the challenging that we have faced. We antibodies means it indirectly tells because the virus is there. Um, of course, they will take. See, these people, like as my colleague is Dr. Reema Sahai, she's works in BSL 4. They're well trained in biosafety and practices. Whenever they know, starting from wearing from a gloves, donning, doffing, and a suit, whatever those people are they trained for that. So when, as I said, in 2023, there was a huge 23 case order. Even the family people did not come to cremate the bodies. These people took the lead and they cremated, and they will take the PP, and it is at the cost of their risk. So they are well practiced for that. So only those expert people will go in the picture and they will train that. So this is the virus replication part. I'll not go into this. So once the virus enters, where and all the endothelial cells, Dr. Bapi has already showed this chip on, organ on chip flavor we have shown. So classically it affects this endothelial cell, vasculitis and thrombosis and obstruction ischemic. And this it's a multi-organ. It can affect, and fatality is very high, close to 70%. So incubation is close to 2 weeks. It can be as acute as 4 days, and longest is even we have observed till 45 days. So that's why once the patient, the primary or secondary index contact cases become, we'll observe them till 45 days to see their and this is like general viral thing, but more mainly affect the neurological. You can see dizziness, drowsy, seizures, altered sensorium, acute encephalitis. Respiratory is also affected, severe respiratory, and if at all person survives, there are consequences, seizures, and I also seen the mental disturbance like personality changes and all. What with respect to our situation is 40 to almost close to 70% we have reported, because in the recent outbreak we have seen 2 deaths, so almost 50% is the mortality. Next slide. Uh, Even pigs are affected, dogs are affected, cats are affected. So not only humans, Nipah virus can also cause, but we can see that mortality, somehow pigs are very less mortality. But even yes, animals are also affected where this is there. And the samples is what how people try to tell is, but we try to take as many as samples. It can be nasal or throat samples, or serum samples, urine sample, CSF. When if person is dead, tissue biopsy samples can be taken to confirm this. And again, the same criteria for storage. This I will not repeat this. Okay. So diagnosis, we have molecular test. PCR is there to identify the Nipah virus, and we also have antibodies based on the sample collection period and the person exposure. We will have an algorithm where we will do both IgM and IgG testings, and there are also rapid diagnostic kits which are already in place to put up, because rapids are like you will do test in the field level. You need not to wait the sample to come from there to the things and all. Immediately once it is put up, small laboratories established in any government hospitals for that matter, immediately the testing happens with point of cares for NIPHA, which BSL4 has been made. And treatment, ribavirin has shown some potency, and this was used in any cases because still we don't have a specific antiviral for this. There are trials going on that, and monoclonal antibodies also, yes, things are going. And vaccination part, I think there are some viruses, there are some potential for vaccines, and they are in pipeline. And with this understanding also, maybe in a few years the vaccine can also be. And anyway, Dr. Bapi team is already working on vaccines, so they are no parallelly, even our people also with integration with others, we are also on a pipeline to develop the vaccines. So these are the real pictures where my friend has shared. You can see, madam, you asked the question whether the people who are going, so they will take the utmost the precautions with the PPEs. So there's a standard protocol how to do donning and doffing and all. They do all these things and all. And also you can see the bags. This is a fruit bag, such a long, almost close to 3 feet bag. You get almost like close to 5 feet also, such a huge bag. And this is how the laboratory established their own hospital labs. We could take over and establish the laboratory in very short spans, and it will be like very well trained technicians will be there in the BSL2 level also with their expertise, and the point of case will try to handle so that reports, because sending the sample to Pune and coming back to Kerala is a long process. Until that, we cannot keep waiting the patient there because he's been exposed with many other people. So if a laboratory is established, this they will be doing within a span of close to 18 to 24 hours, and immediately the testing will be taken over. So this is like what we can see that Toti is there. The person morning he goes, so whenever he collects, he also tastes that, and that if at all it carries the virus, it comes. And classically, you can see the bird eating the fruits. We have seen that during these seasons, the people in Kerala will have great loss. If at all one NIPHA is reported, these fruits, rambutan, guavas, these fruits, whatever they grow, it'll most of the time it goes to the Mediterranean regions. Those people don't take up the fruits, and these people will just leave it. It is either infected or not infected. It is just left, and it's a great loss for them. These things are happening frequently, but still government may give minor compensation, but not up to that much. But these are the real pictures where birds are eaten the fruits, and that's how the toady control. Here a good awareness of this. See what to do about the toddy. We cannot do any autoclave, or we cannot do anything and give it to the candidate. It's very difficult. So, but we are trying to establish that link. If until now, whatever the toddies we tested more than 1,000, and we could not get any positivity in that. Our BSL4 has done that work, but it has not. But when you say the fruits and all, even the fruits swabs were taken and tried to get the virus. That also we could not do that. Uh-huh. Yeah. No, even if they don't survey also, even the dead virus is enough for us to pick up. But we could not establish that link till now. It's only in hypothesis chances are there. Okay. Okay. Hmm. Yeah, maybe this is a good, but I will talk to the team and see if, because once the toddy sample is taken, maybe some part of the toddy sample is taken. Hmm. Agree. No, if that concentrating procedure they are doing and trying to see that, I'm not sure on that. I will try to figure it out, because for the sewage also the same thing happens. Whenever we take the sewage samples, again there's a separation or filtration method we try to do. So that anyway, I'll talk to the team and see what is the procedure they have, because as you said, taking the sample and directly testing it is diluted. There's no option in that. If it is concentrated, definitely it makes sense. Agree, agree, agree. Okay. Agree, agree. Hmm. Agree, agree, agree. It's a very agree, agree. So in this, actually, there are people we have seen they followed it close to 2 years, but I'm not sure about the titers. What is the titer? That is one thing, and also I think recently we are also looking for a monoclonal development for this. Even that is also parallelly going on. But this following up the case, known case, look into the antibody titers. I will just check with the team if they are doing it or already they have some samples. Agree. Yeah. So, Dr. Bapi, with respect to the KFD, I can tell because last when I was there, we have taken sample close to 20 months. So it's close to touching to 2 years, and we could see that samples still they carry IgG. It's only a uh, yeah, yeah. Agree, agree, agree. We can use that. Right. So other emerging and re-emerging virus is JE virus is known to us. So MERS coronavirus, which was already in the list, chikungunya virus, dengue virus, Zika virus, Chendipura, buffalo pox, Iguama virus, Ganjam virus. So these viruses were I think our is Iguama and Ganjam, and there's one more Kaisodi virus, which is all identified, which are anticipated like they can have the potential of re-emerging and manifesting a major human health impact. So this is thanks, and if any questions, we can take it. Achha, it's 120. Okay. It's a very good question because we have seen this. Even death monkeys from Esargata we got called because Esargata is very close to Bangalore. Even there also people report us we got a death monkey and biopsy is done. We need to test. We definitely accept those samples, but the main reason is because monkeys na sometimes people catch the monkeys they may come or some whatever the reason by transportation they can travel and come across. So and otherwise sometimes our local monkeys rhesus monkeys which are very common they can also die, but we do take the samples. We do say but until now I think 2 or 3 such autopsy samples were tested, but none were positive. Huh. Agree, agree. Mm-hmm. No, no, no they deaths are more. They are 60%. They are more affected actually. At least we are like lesser than 10%, but their mortality is very high. That's agree. That forest people we have seen these monkeys, the home dwellers, people who stay there regularly, they have become very good connection with them. They often come, they feed with bananas, they're like they come in contact, they play with kids. It's very difficult to avoid that situation because they have that bond with them. So So this is for the monkey samples? Okay, okay. Because maybe then we need to connect with the veterinary section. Commonly, they do have the pig samples. Usually, they do so many studies. But the primate samples, they may have, unless until they have any illness in that the samples, they might not have been taken. Yeah, yeah, yeah. That thing was worked out for humans. That's why we could see Gujarat and Bengal also. They showed IgG positivity. So, but the monkeys, yes, yes, monkeys. Agree, agree, agree. Fine. Any more questions? No, it's our institute which I'm representing. So, but maybe in coming days, the integration collaboration. So we need to expand our things so that whatever the work is happening, we need to collaborate. Then only it will be more like expand. We can progress still in a better way. Yeah. Yeah. Thank you. Thank you. Yeah, that's what the info. At least some this is very important.